Media internship at the Discovery Channel, an American Medical Association Foundation Leadership Award, an AMA Paul Ambrose Award for National Leadership Among Resident Physicians in 2009, and she was selected for the AMA Inspirational Physician Award in 2015. The American College of Physicians selected her as the 2013 recipient of the Joseph Johnson Leadership Award, and the Massachusetts ACP selected her for their Young Leadership Award in 2015. In 2017, she received the HMS Amos Diversity Award and Massachusetts Medical Society Award for Women's Health. In 2019, she was selected as the Suffolk District Community Clinician of the Year for the Mass Medical Society. Okay, and that's just for starters, but we'll stop. And last but not last, Dr. Eileen Ash is professor and division chief of biostatistics and health services research at the Department of Quantitative Health Sciences at the University of Massachusetts Medical School. She's an expert on risk adjustment in health services research and has pioneered tools to use administrative data to monitor and manage healthcare delivery systems, including many now widely used by the US Medicare program and the Department of Health and Human Services. In 1996, she co-founded DXCG Inc., a company with now over 350 national and international clients to promote fair and efficient healthcare via predictive software. Since 2014, she's worked with the Massachusetts Medicaid program known as Mass Health to develop risk models to account for medical and social risk factors. More than 200 research publications reflecting longstanding interest in women's health, gender, age, and racial disparities, quality, equity, and efficiency in healthcare finance and delivery. She's also used her statistical expertise to advance gender equity in pay and to improve the integrity of US elections. Wow, what a panel, huh? Let's applaud them now. But I think we're starting out. Fatima is going to introduce her short film. Is that right? Yeah.
Great. Okay. Or I can do that. All right, perfect. I can stay seated. Can you all hear me all right? Can you project? Great.
Is it on right now?
Probably not.
All right, great. So again, thanks for having us here, and I'm really grateful to be in this space. Just want to go ahead and introduce the film first before do some more conversations about why I'm here today. So I graduated in May of last year at School of Public Health at Boston University, and during my time there, sort of getting tired of sitting in the classroom and reading research and hearing professors say, you know, Black mothers are dying, their children are dying. And it doesn't matter how much education you have or how rich you are, there's nothing we can really do. And I was sitting there like, well, why am I here? Like, I thought, you know, the higher I get up, the more education I have, I could sort of negate some of those factors. And so during my last year, I wanted to do some work within the community and really ask the question behind the numbers, right? So I think a lot of times when we look at the research, we were talking about protective factors and risk factors that are making some of these issues happen, but who are the people that are talking about this? And so for me, it was really important to really ask who's the narrator and who has the power to talk about their own stories. And I believe that using storytelling as a tool for Black mothers to actually talk about what it is to be a Black mother and what their experiences are is the most important thing. So that's the film that you will be watching. It's about an 8-minute film. And before we start the film, I ask people all the time to take care of themselves. A lot of times when people watch this film, it can be emotional. I don't know how you all are coming in this room today, what your experiences are. And so if there's any emotions that come up, just be aware of that and do whatever you need to do to take care of yourself. And I invite you to also witness these women's story. I think the power of storytelling is to really actively listen and hear what these women have to say. So I invite you to watch the film. Thank you.
What I like most about being a mother, I think, is being able to be in partnership with a tiny human. And that can be both really challenging and really inspiring. And I think that there are these moments, big and small, that come up at all unexpected times that help me think about, like, what does it mean to grow and to develop and then to be nurtured, both for him and for myself.
I could live my whole life worrying about what other people are bringing to the table to oppress her. Or I can spend a whole hell of a lot of time loving her, nurturing her, valuing her life, and showing her that she is not only meant to be here and she is as equal as everybody else, is to show her her assets.
My daughter's biracial. And so that's a whole other thing for me. Like, I don't know how to teach her to be biracial in this society. I only know how to teach her how to be a Black girl. And in our society, being Black is not a good thing. Kids as young as 3 recognize race and racial differences. It's up to us as parents to give them context.
As a woman of color, when you are at the hospital, often you feel a bias.
Going back and forth with all of the nurses, one of them came in and was like, saw my husband and was like, oh, she's gonna have beautiful curly hair. And I was just like, oh, I don't want her again, and just, I was banning nurses left and right. It was my only saving grace was that my OBGYN was Black and understood. She understood that I was under more stress than the other white people women that were on the floor. She understood that I needed injections of Blackness. She came by with poems and songs, and she just sat and talked with me. There is something really powerful about a well-placed girl. Like, that is, as soon as she said that, I was like, oh, okay, I'm in a space that, like, I can be all of me, right?
There's just too many layers of this that I have to fight through to get the person on the other end to look at me as a human being. So yes, I say race, but then I also say, I think another thing that contributed was class. Maybe if I walked in as an attorney, as a Black attorney, the treatment would be a little different. But I walk in as a single mom, right? No partner, I'm sick. And the only thing I can think is either I get really sucky insurance and you determine how you're gonna treat me based on my insurance, or what else could it be? Because there are other women that come here and they walk out a lot happier than me.
Other challenges that I've had since my son has been born have been around issues of equity as related to education. And I think that what I've really tried to do is to make sure that he is in a place that's going to nurture him, that's going to encourage him to be free, that will instill a really strong sense of racial identity. And those places are not sort of everywhere.
With We the People, we educate little kids to do work around equity and social justice. And a lot of parents are like, whoa, wait a minute, my child should not know this. They have the luxury of their kids being in a bubble, and I don't have that luxury. There's a fear, right? It's a double fear, right? I don't have a Black son, and that's a totally different fear. But the other fear is that like I am scared walking down the street and seeing, with my daughter and seeing the police, There's a real feeling of fear for that. It's not because of what can happen to me, but what happens to her, right? Like, she can grow up without a mom.
I overly hug her, I overly kiss her on purpose. So at this point, she's kind of like, can you not so much? I'm like, okay, so if you feel like you're filled up enough, then you're not going to be looking for it out there. So my relationship with my daughter is about everything that we've encountered. We've done it together.
I think that what we have to do, all moms have to do, Black moms have to do regardless, is we gotta build coalitions. And so we gotta share resources, we gotta talk to each other. And as much as I'm, again, devoted and dedicated to the outcomes for my child, I will turn right around and fight for my neighbor and for other Black kids too. My child's future is as connected to other Black kids' futures as anyone else's. And I'm as responsible for them as I am for him.
When you look at your child and you see love, you look at another child and you see love. And that is the real bridge.
I want her to be free. I want her to be able to walk down the street, not move out of anyone's way, and be able to say whatever's on her mind without being labeled. I want somebody to be able to say, wow, you're so articulate, without it having something else behind it.
Well, I think my hopes and dreams for my son would be first that he is free and that he emerges into adulthood, one, alive, two, whole and happy.
A lot of what I do is absolutely intentional because I also know what it's like to be a young woman myself. And the one thing I couldn't have is my child out there needing someone else when I want to hope that I'm all of what she needs and everything else is because she wants it.
So let me just outline how we're going to proceed for the next hour and a quarter. I'm going to ask each of our three panelists to talk about their own perspectives on the issue that we are confronting here in this session today, about 5 to 10 minutes. Then we have a set of questions that we're going to use as discussion among the panel, and then we're going to open it up to all of you. Okay? So 1, 2, 3. And we'll start with Fatima, from wherever you want to handle it. Where you want to take it.
Great. I feel like this room isn't that big, and can everyone hear me? And you can just show of hands if you can show me that you cannot.
Workout World is extending its no payment system.
Sorry guys, that was not supposed to happen, but Workout World is really excited about things.
They are recording.
Sure. Yep.
I'm so used to facilitating that I just feel like, okay, time to get in the middle and talk. So first, thank you all so much for watching the film, and on behalf of the mothers, just thank you for witnessing their stories. And I always want to just take a moment for folks to just sort of observe what's happening, right? Like be present with what happened while you were watching the film. And just to think about whatever is coming up for you, that's perfectly fine, but to just be aware about what's happening inside of your body. So, of course, as a public health person and as a professional, a lot of times people don't realize that feelings and thoughts, whatever reactions that you have, do impact your body. And I think it's always important to sort of bring us back to this place to have this conversation before moving forward. And so this short film, very grateful to have the opportunity to do that. These 3 women that were on the screen are all from the Boston area. And so everything that you heard there is their experiences as being mothers in the Boston area. And for me, it was really important to highlight what does it mean to be a mother. As I was saying earlier, a lot of times when you do read the research, it just feels very sterile, right? There's no story or soul behind the research. And so what does it mean when we're talking about maternal and infant mortality rates, and who's telling those stories? And so some of that work started with me just saying, okay, so what's happening in Massachusetts? We know that Black mothers are about 3 to 4 times more likely to die of complications during childbirth compared to white women. And we also know that Black infants are about 2.3 times more likely to die compared to white infants, right? And so, Massachusetts is an amazing state. A lot of folks compare themselves to Massachusetts, and when we're talking about how do we improve health outcomes. And so I was a little bit afraid because I was like, okay, if I go look at this data in Massachusetts, there's probably nothing to find. Granted, I've only been here for 2 years, but now I guess I'm claiming Massachusetts. But our stats, while not as horrible compared to other states, there's still some inequities in a lot of areas. And so if you look at the Boston Public Health Commission, the report, I think it was 2016, you can see that in specific neighborhoods, specifically Dorchester, with the zip code 02121, 02124, 02122, 02125. Those 4 zip codes are usually the zip codes where a lot of people are having infant mortality rates that are higher compared to the rest of Boston. And so what that means, you can probably assume what that means, but a lot of the folks who live in those areas are predominantly minoritized groups. And I say minoritized because we are not minorities. In the global scale of things, people of color are not minorities. And so really thinking about what that means when thinking about storytelling, right? So wanted to go out and put a story to that. And what happened was I sort of proposed this project to a team called Envision, and they are an amazing group of people. And I said, here's what I want to do. Can you help me? And the woman, her name was Tariana Little, or is, she's still here. And she said, I'll do it for you. And I was like, okay, this is great. I don't have any money. And she was like, no, pro bono. And I was like, oh my gosh, the universe, the stars are aligned. Like, this is amazing. And I did most of the legwork, and it's interviewing women, right? That's next. So we put out a call, and we sort of said, who would like to tell their stories about their motherhood experience? So I interviewed about 20 plus women, about 30 minutes each. And what was interesting to me is that opportunity for a lot of those women wasn't about being on the film. It was about having someone to listen to their stories, right? So I talked to a lot of people on the phone where they were like, Fatima, doesn't matter if I'm on the film or not. I just have never ever told anyone my full birth story. And for you to be able to witness that for me is super powerful. And no matter what kind of research you're doing as a human being, to hear that on the phone, on the other side, is one of the most powerful experiences I have ever had. And so to be able to do that work and then select 3 women who we felt their narratives were slightly different, and to be able to explain what are their experiences at the intersections of race, gender, and class was helpful for us. And so one of the frameworks that I love to share, and one of the frameworks that I used while doing this was reproductive justice framework. By show of hands, how many people have heard of that framework? Reproductive justice framework, yes? Just a few people. And so the reproductive justice framework is a framework that sort of combines social justice and reproductive rights, right? And so if you all were able to hear some of the keynote speakers address earlier before this, when we're talking about human rights, a lot of times we have a lot of models and frameworks that exist, but they're not necessarily social justice based, right? And so what does it mean to have a framework that sort of highlights beyond what's happening in the hospital? So a lot of times when we are hearing stories about infant and maternal mortality rates, they're in the hospital. That's where the story begins. But what's the narrative before that person enters the hospital and after that person enters the hospital? I think a key thing to also mention is that I'm using the term women a lot, but very honestly, that is a very not okay term, because a lot of folks who are able to give birth are not necessarily women. They don't identify as women, and that's usually a gender term. And so that was also part of figuring that out, and what does it mean when we're talking about access to care, and what does it mean when people are telling their stories and how they identify. And so really having all of this in perspective, storytelling for me was the #1 tool that I thought would be helpful to bring these women's stories to light, because first what storytelling allows you to do is to connect with the person interpersonally, right? And then another thing is about access. So we decided to do this film because a lot of times I'm in the classroom and I have access to this research, But when I'm talking to my mom, who's a Black immigrant, she doesn't know what I'm talking about, right? And so what does it mean to produce a film where it's not just people in academia who have access to this and we're all sitting down having acute language and conversation about what's happening in communities? What does it mean for another Black woman, a Black person in the community, a Black mother to listen and hear to another Black person talk about their experiences, right? And so being able to do that has really allowed us to continue doing this work. We continue to share this film. We're doing a lot of workshops in the Boston area, in the community, and continuing to use storytelling as a tool to connect, to heal, and transform. So one of the things that you heard in the last piece of the film by Dr. Kim Parker was the connectedness, right? So when I see you, she said, when I see another child, it's like I'm seeing my child, right? And there's a connectedness in that. So what does it mean to create radical love and radical care within the community as we're making changes to policies and we're making changes to healthcare? And there's just one quote that I'd love to share that talks about the impact of storytelling. I think will really set the frame as we continue having this conversation. And so this quote is from the Reproductive Justice book, and Loretta Ross is a person who is very well known to create, or the mother of reproductive justice framework, and this is from that book. So stories through storytelling is an act of subversion and resistance. They help us understand how our human rights and the human rights of others are protected or violated. Storytelling is a core aspect of reproductive justice practice because attending to someone else's story invites us to shift the lens, that is, to imagine the life of another person and to re-examine our own realities and reimagine our own possibilities. And so I think this is really powerful as we think about what it means to recreate and to make changes in the communities that we're in. And one thing that I love to tell folks is that when we're talking about storytelling, people are not their stories, right? Their stories are what they're experiencing. And I think a lot of times when we look at the research, we sort of have this idea and narrative of what is happening to Black people in Black communities and Black mothers. And to be able to show that full story of what do they enjoy about being mothers and their hopes and dreams is really helpful for us to continue the conversation. So, thank you.
Thank you, Fatima. We'll turn it to Dr. Cody.
Cody's my maiden name.
Forgive me.
So, hi, how are you guys? So we're gonna start, I wasn't actually initially planning on starting here, but I do think that this is important to kind of set a framework. She's trying to send to center screen, so I'm gonna let her do that. As she's talking about that, I wanna thank my dear friend and colleague here for his introduction. I do want us to acknowledge that Martin Luther King stated that of all of the forms of injustice, that injustice in healthcare is the most shocking and inhumane. And so as we think about the injustice in healthcare, I'm going to frame this on what it's like to practice as a Black woman in this field. What we do know about minoritized, which is new to me, a new adjective that I learned today. For physicians that are from underrepresented minority communities like myself, we are more likely to deliver care to persons that look like myself. But let's take you back to November of 2018, so not very long ago, to what I experienced as a Black woman physician here in the US. This will be about a minute and 30 seconds, and then I'll get into my discussion.
When Dr. Fatima Cody Stanford saw a fellow passenger hyperventilating, she started to help. A flight attendant asked if she was a doctor, so she took out her medical license. Then a second flight attendant asked if it was really hers.
People traditionally see a physician as a white male, and for many obvious reasons, I do not fit that bill.
Stanford tweeted to Delta, very disappointed that your policies on diversity have not led to any change. Delta came under fire in 2016 when when another doctor, Tamika Cross, was turned away as she tried to assist a passenger. Delta then said flight attendants would no longer require passengers to show medical credentials before offering assistance. Now the airline is apologizing, saying we thank Dr. Stanford for her medical assistance and are sorry for any misunderstanding that may have occurred. It's another example, some say, of bias against people of color.
You don't just have to use epithets and beat people down. You can just hold high the banner of skepticism about their skills, doubt about who they claim to be, and that is the same kind of force.
And tonight, celebrating diversity. What a doctor looks like is trending on social media.
Well, a doctor looks like me.
Kristen Dahlgren, NBC News, New York.
Hey, NBC.
All right, so, I contemplated whether or not to introduce that today, but I think that with Dr. McDonough kind of giving you my abbreviated CV, it's 76 pages in duration, an actual length, you can imagine what it must feel like to do as much as I've done thus far and continue to do and be questioned about my ability to render care as a physician when practicing at what is arguably one of the top hospitals here in the United States and around the world. So as a Black woman who practices medicine, who dedicates my life to the care of the patients that I serve, I'm questioned about who I am and the level of care that I'm able to provide in an emergency setting, nevertheless. And I want to give you guys a little bit more of a framework. The patient of question in this situation was seated directly to my left. So I didn't even have to get out of my seat. I was in 9B, she was in 9A. We couldn't decide who gets the armrest. And despite showing my medical license twice, which clearly indicates what my status is, I was questioned about my ability to render care and then asked, and it was Fatima, this is Fatima. Fatima C. Stanford, is this really my license? So after 25 additional years of training, with 2 residencies, 2 fellowships, and spending time here at the Kennedy School, and School of Public Health, and med school, and all of these things, I'm still questioned about who I am. So if that's the case, if I'm going to now deliver care to communities of color, how can I even begin to deal with the work that I need to do with patients if I myself am questioned about my value, my worth as an individual, as a professional? And I think that that's of significant concern. When we look at academic medicine, persons that are in academia that are from African descent, only 2.7% of us in academic medicine, and that's not just in the Harvard community, we're looking at the entire academic medicine community. And this is what I'm facing at this point in my career. I face things obviously along the pathway, but I need to now go out and have the energy and the wherewithal to deliver care to communities of color, when this is what I deal with. Now I can tell you that when this happened in November, which was obviously, this is very fresh and very raw for me, my patients were infuriated. How dare you question their doctor? How dare you? I had things coming to my home from my patients. Not that the medical community didn't reach out, the American Medical Association, National Medical Association, and those communities that are my communities of organized medicine meant something, but my patients were like, how dare you? The audacity, the person that calls me at 10 o'clock at night because I'm caring about what's going on with them, you're questioning her and her abilities. Now, my work is in obesity, and people often think of obesity as a lifestyle condition. Like, if I just eat less and exercise more, then I can regulate my weight. And what I did in 2013 was speak to the American Medical Association before they had their landmark vote to acknowledge obesity as a chronic disease, because indeed it is. We don't have enough time for me to discuss that. But when we look at the disparities surrounding obesity, which is by far the most prominent and most prevalent chronic disease here in the United States and around the world, we have 40% of the US adult population that has this disease of obesity. Approximately 20% of the childhood population here in the United States has obesity. 10% of the world's population has obesity, so we can consider this to be pandemic. Let's look at African American women, since Fatima has set me up for that, and I just love being on a panel with Fatima. I'm going to say that multiple times, because it's never happened, and I can tell you guys that I speak like 5 times a week. I was just in New York 2 days ago, I was in Dallas 3 days ago, so I talk a lot, and this is just amazing to me. But when we look at the prevalence of obesity with regards to African American women, 60% of women that are of African descent here in the United States have the disease that's obesity. Another 20% are classified as overweight, which means that 80% of African American women, according to the current BMI guidelines, have overweight and obesity. Part of what drew me to this work was that number, and that number has definitely become more pronounced since I began this work back in the 90s. But I was drawn to this work to figure out, why does that disparity exist? It is a problem for our entire community, and my patients do represent a cohort, a very diverse cohort, but what is it about people that look like me that makes us more likely to suffer from that chronic disease in addition to other issues such as infant, maternal mortality? There are things that happen. Now, it was really interesting. Arlene and I were having a little chit chat on the side, because I tend to do that, and I apologize if I'm disruptive. But that's just kind of who I am. And one of the comments that was made in the film that Fatima showed was that, how would it be if I were in the hospital if she had these additional degrees? Well, I will tell you what it's like, because I was in the hospital, unfortunately, last year at my hospital, where everybody kind of knows me. And what I experienced in that hospital in terms of errors and issues specifically that I think were attributed to people not believing that I'm a doctor despite that I worked in the hospital, that I was giving care, was deplorable. And so, yeah, my degrees, the 4 of them, didn't help me mitigate any of those issues. So I felt very much like you felt. When I'm teaching, like I teach my medical students at Harvard Medical School, how to take a manual cuff pressure of me as I'm just coming out of surgery, because the automated cuff stopped working in my room. And my brain has to switch into my teacher role to teach the person that's trying to take my blood pressure how to take my blood pressure when I'm just coming out of anesthesia from a 6-hour surgery. That's what happened to me and my own hospital. And yes, I will call out MGH, and they've heard me do it. I don't know why they still let me talk. MGH asked me to do a podcast recently on practicing medicine as a Black woman. They initially wanted me to talk on obesity, which is really where I spend most of my time. But this incident happened, which kind of got a little bit of international attention. When I say a little bit, it was in every major news outlet in, I think, 140 countries. So I'm somewhat recognizable. I try to hide myself in the train. My dear Victoria was with me in the train and tried to cover things so people would. But you know, it's disturbing. And you know, the MGH Charge podcast, if you guys want to kind of continue this dialogue once we finish this, is I think something really important for you to take a listen to, because I talk about what it's like. I talk about what it's like to go and see a patient, and this hasn't happened as much as I've been, you know, in the attending side of things. But I remember being a resident physician and going to see a patient, mother that was being discharged from the newborn nursery. And I used to wear a white coat then. I don't wear a white coat because my outfits are cute, and so now I don't like to cover them with my white coat. But I wore a white coat then, you know, because you're a resident, you wear your white coat. So I went to go see her, took her newborn back to her, did another assessment, went back, and then as she's doing her discharge, the nurse is doing her discharge that day because they have to see the doctor. She says, "Well, have you seen the doctor?"
Yeah.
Somebody say, "Yeah." And the patient's like, "No, I haven't seen the doctor today." So I'm sitting at the station doing my clinical notes, and I hear this, and then the nurse is like, "You haven't seen your doctor?" And so I realized that this is the patient I've seen in person twice in my white coat. And I walk over and I was like, "Excuse me, have you seen me today?" "Oh yeah, I've seen her." I'm clearly your doctor. I clearly had on my white coat, not the cute red dress. But the whole point is that even in the role that I'm sitting in and trying to deliver the care to people, I'm still not valued for who I am. How are we then to train a workforce that looks like me when they're in that workforce, we're questioned for who we are, and we can't deliver the care we need to patients? So I'm going to stop there. I mean, I can get into a lot of issues, but I think that those things are extremely germane to what happens, not only with me here in Mass General Hospital, but what happened to my colleagues throughout this country. How much training do I need? Is 4 degrees not enough? Is 2 residencies not enough? It's 2 fellowships, not enough. Obviously, it's not enough. Why can't I just be valued for who I am and my worth in this profession? Because if I'm not valued, I can't deliver the care I need to, because then I have to check in with who I am. I'll stop there.
And, yes. Arlene Ash.
Hello.
That's it.
Okay, and could I have this screen on? Is that possible? Otherwise, okay, this is a change of pace. I want to tell you about work that I've been doing for a long time now, starting in the middle 1980s, and the place that I often start. Let's see, where am I clicking to?
Well, you can move the slide.
Where is the,
You can just click in front of you.
We can turn for you, Arlene, or
okay,
you can come up
next
and
slide,
stand.
next slide. Okay, so I often start with a who am I slide, and sitting through this conference, I've been reminded that I was an undergraduate at Radcliffe, Harvard in the 60s, and at a time that I was telling Fatima that they didn't let women into the undergraduate library, which people are often shocked to hear. They say, there were a lot of libraries, but you couldn't go to the one where often some of your books were coming out of. You had to ask somebody to go in and get it for you. But I was a math major, and this was in the period before the protests over the Vietnam War bust out all over campus, but there was a lot of social unrest, and I was kind of jealous of the people who were studying social things because it felt so relevant. But I have come to feel, and I want you to come to understand, that if you develop a technological skill that's important, it can actually make a difference in some of these problems that we're talking about. So don't give up. Don't think that you have to be a sociologist in order to do something which has to do with social problems. So since 2014, our group at the University of Massachusetts Medical School has been working with our Medicaid program to develop models that help the Medicaid program manage itself. And the field that I work in is called risk adjustment, and I'll tell you a little bit more about what that is. But the task that was put in front of our group was, how do we expand our way of thinking about what it takes, what resources are required to deal with health, if we think about the social problems that people face as well as their medical problems. So I want to talk about how we structure, how we pay for healthcare, and the role of my thing, Queen of Risk Adjustment, and the social determinants of health model, and what this means. So what does a health insurer, a public health insurer such as Medicaid or Medicare, what are they trying to buy? So they may pay for a particular thing, but what they're trying to gain, what they're trying to buy with their dollars is health. So the medical system was not designed to produce health. It was not particularly designed to manage chronic disease. And health is a complex problem. Unlike deciding we're going to go to the moon and we have a bunch of engineering problems to solve and we set people with their slide rules to figuring it out and we'll get there. There's one way to get there. Achieving health is a complex problem. There is no obvious single way to get there. And we really need to engage the minds and the hearts of our community to get there. So we are trying, at the moment, what we do is we provide access to a type of insurance that is supposed to make sure that when you need health care, you get it. But many Medicaid programs, including the one in Massachusetts, are trying to rethink how we can try to use Medicaid dollars and possibly other dollars that can be found federally or locally to purchase better value in terms of health. So I want to talk a little bit about a big shift that's happening across the country, and maybe the world actually, in terms of a change in how we pay for health care. So traditional health insurance in this country and elsewhere has been fee-for-service based. And what you do is you sit down and you say, what do people need that when they get sick, what do you need? And we'll pay for it. You put somebody in a hospital, we know that costs something, we'll pay for that. You give them a service, we'll pay for that. And so we break it all down and we say each thing that we think contributes to the health of a person, you give it, we'll pay for it. And these alternative population-based health models are very different. They say, we're going to ask you, and we'll think in a moment about who you is, but anyway, we're going to ask you to take this money and use it to sustain, maintain, improve, protect the health of a set of people. So it's very different. In one case, you could be buying shoes, and you could say, this is the price of this shoe, this is the price of that shoe. In this case, this other case, we have a much more holistic sense of what it is we're trying to accomplish. You're going to be caring for 100,000 people who are in this program, and we want you to use that money well to take care of them. And we're going to need to make sure you don't just take the money and go to Tahiti. We're going to need to see that certain things that are guaranteed that these people should be able to get, that they get. And we're going to try to see if you're using the money well. And we're going to try to have little experiments. It's your group that has an idea of how to care for people. Are they able to use that money in a way that is more effective than other groups? And maybe we can learn from each other, and maybe we can propagate the most successful models for how we deliver health. So that's the shift that we're trying to undergo. We're not talking, we used to talk about disease management, we now talk about case management. So you're not saying, oh, you've got diabetes, you're a diabetic. Hear that language. You're a diabetic, you're defined by your disease. No. We want to say, your person, one of the things you have is diabetes. We are trying to figure out what can we do to help you manage that, to help you to learn how to be a partner in managing that. And anyway, so when you pay fee for service, you get a lot of service. And you get a lot of low value services, because people are in the business of giving services. The more service they give, the more they get paid. When you pay a fixed price and you say, take care of this population, you have to watch out for stinting. You have to watch out for denial of care that people actually need. So no payment system is going to solve all the problems, but they have different, you have to think carefully about what the problems you have to watch out for. So an MCO, a managed care organization, we now have new language. We talk about accountable care organizations. And the language of the accountable care organization is to say, we are asking a bunch of providers to form an organization in which they have all the services needed to really help make people healthy. They don't just have a hospital or access to a hospital. They don't just have clinics or access to clinics, but they have behavioral health services. They have health aides who will go out to your home. They may have community health workers who will act as peer coaches, who have the life experience that can help them to relate to what problems you have and help you figure out how to access services and how to take better care of your life. So in theory, in theory, this way of reorganizing healthcare has great potential. In 1995, I was called to testify before Congress, House Ways and Means Committee, about some of the work we'd done, which was going to lead to opening up the Medicare program to these managed care organizations. And the head of the committee said to me, Dr. Ash, I know that doctors take the Hippocratic Oath, but these companies, I don't trust them to do the right thing. And I was like there to talk about my risk adjustment models. I'm just a mathematician here, you know, and I took a big gulp and I said, I think I came up with absolutely the right answer. I said, we don't know if this way of doing healthcare differently will be better or worse. It has different risks, it has different opportunities, but we won't know unless we set up a system in which these organizations, however they're organized, they could be like Kaiser Permanente on the West, which started in the West Coast, a very, very interesting alternative way to offer health maintenance, health care. We don't know the answer, but we can try to set up a system in which there is the possibility of doing things that fall outside of fee-for-service medicine. This woman comes into the hospital time after time during the summer, whenever the air is bad because she can't breathe. What about buying her an air conditioner? We can't buy an air conditioner into fee-for-service, but if you were managing that woman's care, you could say, maybe that's something we could do. Maybe that would be a wise way to spend our money. So the goal of this shift from fee-for-service medicine to population-based payment, to assigning a panel, is to say now there is a group that has a budget that can think about, in a proactive way, can think about what are the needs of this population, and let's deal with them before they come in sick. Let's take the people who will come in sick if we don't deal with them, and let's try to deal with them. So that's what we do. The big problem that I was brought in to help solve is risk adjustment, which is to say, if the state is going to be spending $6,000 a year on the health care on average, for everybody in the Medicaid program, you can't just give $6,000 for every person you sign up. Some of the people in this program are not particularly sick. They're just kids in low-income families. They're not expected to cost $6,000. You don't, on average, need those resources. Maybe you need half of those resources. And if you find a person who's really sick, nobody's going to want to take care of them for $6,000 a year because you can see that they're going to cost $60,000 a year. So the goal of our work is to set prices at the level of expected resource needs from the healthcare community. And if we do that right, then we have a fair level playing field in which there could be an accountable care organization which says, we're going to make it our business to take care of really sick people. And we'll have a budget which makes it adequate. And we do such a bad job in this society of taking care of really sick people that there should be enough money to do it a whole lot better if we're proactive. So that's what our team does. We sit there and we look at the data and we build models which try to get the right amount of money in the right place so that it's possible for a healthcare organization to care for sick people. Okay? So our model we use administrative data. We use the data that's generated during everyday care when you see your doctor and she does something for you. There's either a bill or a dummy bill, an encounter record that's generated that, thank God, follows a uniform format because Medicare set it up. And so we can read these bills from all over and we can relate what your age, sex, your medical problems that you've been seen for during the last year, and some other things that we know about you because you're in the Medicaid program. So disabilities, we know something about that. We picked up unstable housing, 3 or more addresses during the last year. These people are not moving from one home in the Hamptons to other places for their vacations. And if there's been homelessness reported. We put dollar values on that so that the organizations that sign up people with greater medical problems or greater social problems get more money so that they can deal with them. We also developed a neighborhood stress score, which is based on mapping your address to your neighborhood using census data to talk about. And I should wrap up because I've talked over my time. So let's go to the next slide. We're getting very close. So you have to get the payments right or your system will fall apart. We really have to give more money where it's needed. Now this money could be used in very creative ways, or it could just be swallowed up by the existing healthcare system because people who have money get to keep money. So whether or not these extra dollars are going to be used well hangs in the balance. And we are in an experiment in this state to see if we can actually get dollars spent in wiser, clever, more valuable ways. So care coordination is key. Having people who are not simply traditionally trained doctors, but who can serve a variety of functions, having them involved in the mix, partnering with social service organizations, all of these things are experiments that we're in the process of looking at. We will be evaluating how successful this Medicaid transformation that's going on starting last year over the next 5 years. We'll be evaluating that. Next slide. So where are we going? We are evaluating these changes. The state has put people who really care about doing this right in charge. I don't know if they're gonna do it right, but I can tell you they wanna do it right. And we'll be looking at it. And hopefully we will be identifying provider systems that really start to use the money that's there differently. Thank you.
By the way, I would just say for the small number of you who are not totally into healthcare risk adjustment, Arlene is probably the queen of risk adjustment in the healthcare universe. It's kind of like being the tallest building in Tulsa, Oklahoma, but I know how important it is. So we have, the organizers came up with 5 questions that I'm going to ask the panel, and I'm going to take the presumption of directing each question to one of you, and then invite the other 2 to make comments. But the sooner we get through these 5, the sooner we open it up, and we only have 35 minutes left. So kind of to the point. So my first question is to Dr. Stanford.
Yes.
Table safe, okay?
Yes,
It's not going to
it's
drive
some
away.
things going on over here.
It's a self-driving table.
It's actually.
So we have continua in all levels of healthcare, but one of those is the continuum from prevention of various forms, primary, secondary, tertiary, into medical care itself. Do you see a difference in terms of disparities and health inequities on the prevention side versus the medical side, one more than the other? Are they layered everywhere? And is there any prioritization in terms of going after inequities that you see, prevention versus care delivery?
So I would say that my answer to your question, the initial question, is that I don't think that there is a difference between inequities that exist on the prevention side of things, which is where I started my life in the medical field, to kind of more of the curative or treatment side of issues. I think that disparities exist across the board. I think that probably one of the major disparities in general in terms of looking at the difference between prevention and treatment is that we look at ourselves we're divergent basically in our approaches. I think that there needs to be a coalescing of strategies to address chronic disease, especially as we look at the change into ACOs and kind of population-based management. We can't just look at, like you said, the person that has diabetes, which is just one of many issues that individual is dealing with, and how that affects the population and the dollars that are being given to a population has to do with the continuum. You know, like if they have prediabetes, so right now the treatment model that's set up, let's if we're gonna use diabetes as a thought process. If a patient has prediabetes, which means they don't have diabetes yet, they cannot get access to a dietitian that they don't have to pay at least $50 per session for. That is cost prohibitive for many patients. As soon as they get a diagnosis of type 2 diabetes, now we cover their dietitian. That appears to me, as a clinician and as a prevention person, to be a bit backwards, right? So we don't allow payment for a dietitian until they actually get the disease of diabetes, which in and of itself is a cardiac risk factor for many things. I think that when we have these shifts in payment models, we have to think about this continuum of care for an individual across their lifespan and what things we can do as an adolescent that might prevent chronic disease and reduce overall health cost. So I know that sounded kind of like a long answer, but I think overall there are inequities across the board, and there is not enough kind of crosstalk between the prevention and the treatment side of medicine.
Okay.
Sounds good.
Question 2 is to Fatima Danke. So let's take the example, because if you follow from your wonderful film, congratulations on that. It's your first film?
Yes.
Hope it won't be your last. But so let's talk about the issue of maternal mortality, which is a shocking, unbelievable crisis in the United States in terms of numbers, in terms of mortality going up at a just alarming pace as they decline in just about every other advanced country. So, what's your reaction, your response? How can it be that we're going in such disparate directions? And can you think of any interventions that you think are the smartest, best ways to get after this?
Yeah, thanks for the question. I think first of all, I forget who said this, but he said, I know it's a he, but I don't remember who, probably one of the presidents. But, if you want to know the value of a country, you want to look at the children and the mothers. How is the country valuing the mothers and the children, right? Because a lot of times those are the community makers or the movers or the shifters. You go to any community, you can get a sense of what's happening in the environment, right? And we see this through a lot of anthropological studies. You can go in a community and a lot of times you see what's happening. And so our country, alluding to your point, when the prompt before asking the question is, we don't value our mothers and children, right? And that's very clear in that what the data and stats show, and there's a site called Birth by the Numbers, great site to keep you updated about what's happening. But if you look at what's happening, even if we got rid of all the people of color in the United States of America, we would still be doing a horrible job as a economically developed country compared to other economically developed countries, right? And so the issue first and foremost is that we do not value what's happening to our mothers and children. And then in terms of the racial gap, what I'll say is, I'll first start off by nicely saying implicit bias, right? As someone who facilitates throughout Boston area around term racism, we start off with implicit bias, right? Because truth be told, a lot of us are breathing in this smog that we don't necessarily know that we're breathing, right? But it has real impacts and effects on how we treat people. So alluding to the point that Dr. Stanford said, is, what does it mean for her to be in the hospital as a Black woman and to experience what she experienced, right? Not only a Black woman, but also a doctor in the hospital that she works at, right? And so that's just one example. These are stories that are consistently happening. So it's not new. Those people who've been in the communities have always known this. Thanks to research that they're like, oh, guess what's happening, right? Like this is a huge deal. But I think it's really important to note that. And then in terms of interventions, there are a lot of great things that are currently happening. And I think the reason why they're successful is because they're not your conventional way of approaching the issue. And they're very much more holistic. So there's a lot of organizing happening in places like California and places like New York, where folks are realizing we can't wait for policies. We can't wait for doctors to be less racist. We can't wait for doctors to figure out, oh, well, maybe if I take this training or workshop, I'll get it. Because it takes time. the way our brains work, we're very unconscious. 2% of our brain is really conscious. So everything that's in the back of your head is how you react. So it doesn't matter if you get this training, the workshop is not the work. It is a consistent work that you have to do. So while we're waiting for those systemic changes, what's currently happening and the interventions that are happening is people are doing storytelling, literally, right? What does the model look like if you have mothers come together to talk about their experience with one another, right? And I think there's a lot of research around patient-centered pregnancy groups. They're seeing a lot of benefits towards that, right? If I can say, hey, this is happening to me, I'm pregnant, now you have a buddy, right? And just the ability to be able to talk to someone allows you to connect and then to know what resources exist in your community and in your neighborhoods. And so with those interventions, a lot of times mothers are able to then say, okay, here's what I can do. Other interventions that are currently happening, even within the Boston area, a lot of people probably know, are doulas, right? So there's a lot of initiatives that are going on to make doula part of Medicaid plans to make sure that people can afford doulas. And doulas are people who are not necessarily medical doctors, but they're trained to understand what it means to be a mother and what it means to help people through either pre-pregnancy, during pregnancy, post-pregnancy. And when you have a doula, you're able to talk to your doula. Sometimes your doula can advocate on your behalf because most pregnancies are unplanned. So, and a lot of times people don't know how to address the situation until they're in it. So how nice would it be to have someone by your side to say, here's what can happen, here are the issues that we can talk about, and here are some of the services that are in the area. And so those are just a few. There's a lot of things that are happening, but then again, it's a lot of times either outside of the hospital or, like Dr. Ash alluded to, the coordinated, integration that's happening. So doctors referring their patients to other people that can provide these mothers with help.
Thank you. That's excellent. Thank you. So, question for Professor Ash.
Knew it was coming.
So the one thing we're really good at in the United States that is absolutely indisputable is just spending ungodly sums of money on healthcare. I mean, we're just second to none. But on so much else, we are just so deplorable. I mean, life expectancy going down 3 years in a row while it continues to rise around the world. Infant mortality, maternal mortality, so many measures. And even Massachusetts, by the way, who like to brag that we're one of the healthiest states, but you compare us to if we were our own nation, and you compared us to the other leading industrial, we would be mediocre at best in terms of how we look. So what do you think it can take? How can we get a handle on cost, but yet advance, turn this ship around in terms of the direction that we're heading, in terms of quality and inequalities and so many other issues?
Well, I'm glad you asked me a really simple, easy question to answer, John.
Beyond beyond value-based care.
So I think that the first thing is to actually commit to doing better, to accept that we do badly, and to confront that, and to say what is needed to do better. We do not value children. We will not invest in children. Why don't we use this language of investing in children? It's very easy to not spend money on health care or education for kids. I mean, you don't notice the problems until much later. But we are just so disinvested in our society. And John, you started with a language about how much money we put into different kinds of social welfare. And in the United States, it's about $1 in healthcare for $1 in everything else. In all the other industrialized country, it's more like $2 or $3 in everything else compared to $1 in healthcare. You have to have housing. You have to take affordable housing seriously. This is one of the biggest health problems we have in this country, the lack of affordable housing. You have to take nutrition seriously. We have programs in this state that are underfunded, that are such good ideas if we would only spend more money on them. There's the Healthy Incentives Program, which gives $40 a month towards an $80 purchase at a community-supported agriculture or a farmer's market or something like that. And we in this state, we could have fully funded it at $1 a person, and we let it run out halfway through the year for lack of funding. I mean, so we have to do research which shows the value and proves the value. I do believe that we are at a tipping point. I do believe that there's a widespread recognition that if we won't spend money on anything other than healthcare, we will continue to spend more and more and get less and less.
Okay, thank you. So, Dr. Stanford.
Yes.
So, social determinants of health, rampant problems with it, it's just a major challenge. Arguably, there's more attention, more conversation about social determinants of health and what to do about it than I've seen in the 35 years that I've been paying attention to healthcare, and we're seeing with ACOs deliberate incentives to try to get at it. What's your sense of this? Where do we need to go? Should we bet the house on ACOs, or is there more that needs to be done to really try to get to where we need to get to as a society on social determinants?
So another uncomplicated question, but no, I think this is an excellent question. I do think that looking at the ACO model, if we look at, for example, Partners Healthcare, right? This was one of the first ACOs, or accountable care organizations. And if I want to look at Partners as an individual entity, which is where I've spent my last 7 years in healthcare, I think that there's a lot that still needs to be done. I do think that physicians, who do practice more of this traditional thought process of a fee-for-service based level of care, have begun to recognize that what we do as physicians, what I do with that patient while they're in their office, is just a very small fraction of what actually happens regarding whatever disease process I'm looking at. The health care that's really happening happens outside of the walls of a traditional hospital or clinic. And I recognize that, and patients recognize that, and doctors are beginning to recognize it, but I still don't think that the payment models are really set up to address that. So Arlene earlier addressed an issue with a person coming into the hospital with breathing issues secondary to no air conditioning, I think was one of the things she said. Why not buy the air conditioner? I mean, they can keep coming into the ER to get nebulizer treatments and spend whatever that dollar amount is on that acute care. But we need to be thinking about what are the things that keep them out of the acute system. And sometimes it's really basic things, such as ensuring that they have affordable housing. If a patient comes in with abscesses in their feet, but they live outside, I mean, do we expect them to be able to really kill that problem, right? So no, they're gonna be outside, it's gonna drop to 20 degrees, they're gonna end back up in the hospital, we're gonna keep this kind of constant, in and out of the hospital doors, but we're never treating the person, and the person, what they need is access to housing that allows them not to be outside, to get another abscess, to have this this kind of circle, this kind of in and out of the door circle kind of occur. So I think that there's a lot that needs to be done. I think that we're beginning to think about it. I agree that there's a lot of conversation, but I think that conversation actually needs to lead to action. And action would be putting the money where it needs to go, which is not just in the hospitals and in the acute facilities. So yeah.
Thank you. And so, final question before we turn it all to you, for Fatima Dante. How can we do a better job engaging community-based organizations in this effort, and not just looking to the medical care community to try to tackle and take on everything? And how can we do that in a way that's really going to matter coming from a community-based organization?
Absolutely. I think that's a beautiful question, because in my opinion, I think because this is such a complex system, and because it's so intentional in the way so many things are integrated and how it's impacting folks, we cannot address the issues one way, right? And so first we need to apologize, right? Like, that's the first thing we need to do. I think a lot of times we think that we're experts, especially even me, like coming from an academic institution and going to communities, a lot of times we think we know what we're doing. And so we go into the communities and we tell them what we want to do versus asking them, what is it that you're already doing, right? So looking at it from a strengths-based perspective, right? And working with organizations, do it right now, right? How do you make sure that you're doing compassionate community organizing? And how do you make sure you're working with organizations and, taking a step back and realizing that they need to take the front seat? And I think when we're talking about social determinants of health, I think it's so easy to think that It's not as hard as it seems, but when you start working with the communities and you realize all the structures that are in place, it does require money, and it does require movement. It requires faith and hope. And another thing I would add is that when you're working with community organizations, not just coming into the community, trying to figure out this goal, you have 2 years to work with them, and then you leave, right? And so a lot of times that happens, and then the program is going really great, the funding disappears, right? And so what was happening in the community can no longer happen in the community because you just wanted to fill out your outcomes, check your goals, and now the community is back to where it started. And so when people go into communities and they're like, they don't trust me. Well, I mean, that's not really a hard thing to figure out, right? And so really thinking about all these key points to address social determinants of health, I think might be helpful.
That's excellent. I think we saw that in Mass Health, the ACO experiment as well, which initially built in a big piece on flexible services to pay for air conditioners, other kinds of things, and then according to the public health people, it became the rapidly inflexible services rather than. So anyway, so we're going to open this up now to you all. I'm going to ask you to please identify yourself, just a little bit, not a long story. We don't need your life story, but just tell us who you are. And it's wide open, and if you want to direct it to one individual or the whole panel, go for it. And let's try to keep things kind of concise so we can get as many people as possible. I'm guessing a lot of people are going to have things they want to say or ask.
Hi, my name is Eric. So currently, like with a lot of political discussion regarding, I guess, like healthcare policies and like the structure of the healthcare system and health insurance, it seems to be growing more and more progressive, especially with the rise of Medicare for All as like one very prominent proposition. And yet, some of its greatest critiques is that it seems like infeasible to fund. I guess my question is, do you guys see that kind of a progressive healthcare model to be like, I guess, I don't know if I should say the only solution, or like, is that going to be the end goal? And if so, do you guys have any responses for these critiques about feasibility financially?
I get to start. So there's a very credible economic analysis of this, of Medicare for All, and the screams that it's economically infeasible are really hysterical. I don't think that it's obvious that we can move there tomorrow, but I think it's fairly clear that we fell into the rather stupid way in which we finance healthcare in this country by accident, and nobody starting over from scratch would do it the way we do it, and that if we had a single payer system, there would be great savings. But that said, you have enormous entrenched interest. I'm not sure that there's an obvious path to get from here to there, and you would not solve all the problems with healthcare by having single payer. So please understand that anybody who is put in charge of managing the dollars to care for the health of the nation is going to have to make some very difficult choices, which there are pros and cons of different ways to do it. There's a lot of research that still needs to be done to understand the most effective ways to do it.
I just add, by the way, if you look at the UK system, which is a genuine single-payer system, disparities and inequities is an enormous conversation in the UK. So just to reinforce Harlene's point that single-payer is one great pathway to get there, and can't make assumptions about then how much it deals with all the other issues.
I had a question for.
Introduce yourself, please.
Oh, hi. My name's Aida. I'm originally from Rhode Island. I had a question for Professor Ash. I think I got your PowerPoint right, but I'm not really good with numbers. So my question is like on whether or not I got it right. So I'll give a whiff at it. So basically, I think my question is on basically you're trying to find like an innovative way to basically get at stopping people from coming in the first place. Basically when you were talking about, if someone's coming in with breathing problems, let's get at, holistic care. So like maybe putting in, what did you say,
By the way, an air condition.
Yeah, an air condition. But my question was like, I'm thinking about the healthcare system and how it's overloaded anyway, and a lot of these doctors are zipping in and out, going from patient to patient to patient, and like really having like a short amount of time to even be with their patients. So, you're trying to accumulate a lot of information in a short period of time. So I'm wondering, like, how can we innovate? And I know that you're focusing more so on the numbers wise of like how do we innovate through money, but like how do we innovate through time?
Yeah, I think that's a very easy answer. I, as a physician, should not be asking all the questions about your housing and things. That's not what I'm trained to do in medical school. It's not what I'm trained to do in residency. It's not the best use of my time. But what Arlene did talk about in her PowerPoint, we're using other persons that are trained in other ways. So using community health workers, using other persons that have ability and may cost less, or actually will definitively cost less than it would cost to have the MD doing that work. I spend a lot of time doing a lot of asking questions. My patient visits do go a little bit longer just because of me being a specialist, but there's a lot of things that could be handled by other providers and it would cost a lot less to the system. And so why not utilize these people that are trained to do this work to reduce costs, but also improve access to care for those individuals? And so I think that we know that those things exist. I don't, in certain, even within our ACO, Partners Healthcare, certain individual clinics do that better than others. I think there needs to be some equity amongst how those additional workers could potentially benefit the system, but I think that relying on the MD to do that is really not the best choice.
I couldn't quite see who you were pointing to, so.
Thank you so much for speaking with us. My name is Noam. I'm at the public health school here. We haven't really talked about the urban-rural divide, and there's a lot of systemic inequities in rural healthcare systems. Much of the proposed solutions and funding has gone towards telemedicine, virtual services. I wonder what your thoughts are, anyone, on how we're losing that personal touch for these rural communities and how that might exacerbate some of the issues that we already have in the biases that we've talked about today.
So I'll talk a little bit about that. I'll be talking in West Virginia next week, and 60% of West Virginia is still on dial-up, which I think is bewildering living in Massachusetts. So what does that mean if we're looking at telemedicine? We could use a model like asynchronous visits, which I do for my patients, where they get kind of an email where they address questions about their weight and diet quality, physical activity, stress, sleep, etc. And I call them at the time that I'm reviewing. So I don't need a fancy smartphone, which they obviously would not be able to even access. And I think, and I can tell you definitively that my patients really appreciate being able to fill out this form and actually speak with me. They tell me what their nightgowns look like. I get all kinds of information that I don't ask about when I call. But I think that that is a personal touch, right? So even though they're not looking at me, we're not looking at each other, they don't have access a lot of times to the resources to be able to pull me up on a system that I would use with my doctors and MGH. They're able to have access to me even in their rural communities. It's not West Virginia. We're not in West Virginia, but a model like that would work in a place like West Virginia where 60% of the state is still on dial-up, which I still find bewildering, and I will talk about that with them when I speak with them next week. It's taking me 3 flights to get there from Boston, not because I want to take 3 flights, trust me, but it's just so remote, and so that means that their care that they're getting is a bit fragmented. So I think that there's ways to navigate it by using technology that may not be as advanced as what we rely on a day-to-day basis, and that can still create a personal touch. That's just my personal thoughts.
Right next. And we'll go over. My name is Max. I'm a graduate of the MPH program. I actually also work at Mass Health on the Flexible Services program. And so my question is for Dr. Stanford and Fatima, because one of the things that is happening in the healthcare system now is that there are dollars being allocated to spend more on health-related social needs and social determinants of health. My question for both someone who works as a clinician and someone who works in the community is how well do you think that the hospital is suited to work with community organizations who do have the expertise to work in something like housing that does not exist within the healthcare system, and how suited do you see the community organizations are to work with the clinicians who are busy and might not have kind of the expertise about what's actually going on the ground and what sort of resources there are. So how do we make that channel more wide open? How do we make it so that the dollars that are starting to flow from Medicaid programs and from some private providers and some private health plans that are identifying this as an important issue, how do we start making the flow of information and the flow of dollars going to the right people at the right place through the right organizations? And is the healthcare system kind of ramping up to do that in an effective way?
I would say we're thinking about it. I can tell you that I had a whole hour-and-a-half conversation about this very issue this week. So with the fact that the conversation was an hour and a half means that we don't have solutions for it. But we're working with the program that's being delivered in the community, specifically in Dorchester, for African American women to get them physically active. They have some dollars that are there. How do they get access to our patients? How do we communicate with each other? How do we keep it HIPAA compliant, which means that I protect their privacy? And I don't think we've yet figured that out. I think that we're excited about the possibility. They have these resources. These are what our patients need. We want to get it to them, but the ability to have that crosstalk of information, I think that we're still figuring that out. So I'm excited about the likelihood of these things happening, but I still think there's a lot of work that has to be done, and there are a lot of conversations that are happening along those lines. I'll let you speak on it.
What I really like to say is that capitalism won't let us do our work. That's just really what it comes down to. It just won't let us, right? And the reason why I say capitalism is because when we think about healthcare, it is a business, right? And these community organizations are trying their best to do what they can with little funding that isn't always necessarily there, right? And so I think in the beginning of your question, you asked about are folks even equipped to even do this work, right? Yeah. And so how do you even start to build relationships? Because I think even before you get into the community and do the community organization, is there even space and time? So a lot of people are coming into communities that they don't know, right? They've never been there, they don't know the people in there, and they're like, okay, we got some money, let's go to Mattapan. We got some money, let's go to Codman, right? And that's okay, reparations, I said that earlier. And I like, people say culturally humble, but I think it's beyond that, right? Really having an understanding of the neighborhood before you even get into there, because I think what will be sustainable and lasting is when you do have that understanding, you're able to approach the situation in a way where when the money is spent, it's spent in an effective manner in a sustainable way. And if you flip the other way around, thinking about people who are in community organizations, it is really hard for folks, even though they want to do this work, it's really hard for them to sometimes stay along the line, right? So let's say you develop the relationships, you have the idea, you have the understanding, you're coming from the hospitals. Sometimes it is really hard for them to carry out some of the action planning because there's so many other things that they have to deal with as nonprofits. So I think the main thing is relationship building, but also as an institution within hospitals, making sure that there are people in those hospitals that can help support community organizations, and making sure that the work can continue is one of the main things. I think even as I continue to do racial equity work, how do you create organizational change? And it's very hard on both ends.
Okay, I think we have time for one more question over here. So make it good.
Hi there, my name's Kaylee, and just kidding. Hi there, my name's Kaylee. I'm a medical student at Dartmouth College, and my question is: we talk a lot about building allyships and relationships like this, and so I know in clinic I've also had a number of things said to me that were very much inappropriate. And what are some of the best environments to engage in these types of conversations to start building allies? And because doing it at the patient's bedside, that's not where you really want to engage in those types of conversations, so that we can start changing perspectives about people from all different backgrounds.
I think this is targeted at me. So I think that it's going to have to happen in every possible area. So at the patient's bedside is one of the areas. We see a lot on social media. Time's Up Healthcare, for example, where we're looking at how women are addressed in medicine. But we do need our allies, right? So when this situation happened with me, some of the prominent voices that came forward were my white male allies that said that, look, I've been on planes several times and no one's ever asked me. I've had on torn jeans, didn't shower, smelled horrible, and people still believe that I was a doctor, and how could you not? Like, this is my colleague. And having their voices come forward, I can say the exact same thing, but when someone says it, that doesn't look like me, that's like saying, oh, I need for you to believe who I am. I think that those voices are extremely important and I think are listened to. So it's about having the conversation in the pre-medical curriculum, starting at medical school, having your professors actually be there to talk about these issues and how these things are addressed. In my time at the Medical College of Georgia, which is in the Deep South, when things would happen at the bedside or when things would happen even in standardized standardized patients are kind of actors or actresses that act out, but if things were said, nobody corrected anyone at any point. I don't let that happen for my medical students, residents, and fellows. I addressed it head on, and I will even say, if you need to be assigned to another team as a patient, if for some reason they're addressing my students or residents and fellows in a way that I feel to be disrespectful, I will directly make that happen. But for me to step up for them in a way that shows support, I think really means something and can help change the dialogue. When I'm teaching at HMS, we do teach a course on health policy, and one of our entire sessions is dedicated towards bias in medicine. And of course that can be racial ethnic bias, it could be gender bias, it can cross many domains. And when I'm speaking with them about their individual circumstances, I think about ways that we could potentially have changed that interaction, things that they've already experienced, and then also think about how to address potential future issues because they will continue to come up. So I think it needs to be happening at the bedside. It needs to happen within the pre-medical curriculum. It needs to happen, but it's not just what's happening in medicine, it's how we're perceived externally, right? So people seeing non-traditional persons in these roles will help change some of that dialogue.
Beautiful. I really love that question because we get it all the time after we do dialogue, so it's everlasting work, right? And I think beyond the medical field, right, how do you create space within institutions to continue doing that work? Because you are right, like you probably can't have that conversation at the bedside. And sometimes there is distrust, so I don't know what comments you might have received, but it could have been comments from either side depending how that person shows up. But one of the things that we usually tell folks in institutions is create space in your organization or institution, and that looks like probably having an equity committee, right? A racial equity committee where you all can get together and sort of talk about some of these things that are coming up and brainstorm, how do you actually address this, right? This patient said this to me, I'm a white person, this is a person of color, I didn't know how to address the situation, what should I do, right? That's a wonderful way to do it. Another way to do it is racial affinity groups, right? I think a lot of times people get afraid and they're scared on like, how do you do this work? But even if it's not an affinity group around race, you can have affinity groups around gender. Affinity groups is just a space to sort of have these conversations. And I think if you can build it in any way, whether it's like a friend in you who's already thinking about starting this, doing that and continuing the work is really helpful because the truth is you're not gonna always have a class that's gonna teach you how to do that. Like that's not what school is really for, right? So a lot of the things that you're gonna learn are outside. So how do you do that work outside of people sort of providing those systems for you?
Okay, and final comment.
What you're asking is an enormous shift in how society works. You're asking for an enormous shift in where dollars go. You're asking industries that have been very used to being fat and happy to get less fat and happy. And it's hard work. And I'm just telling you that it's wonderful work, and I think this is an extremely propitious moment to engage in it, and we urge you to do so.
So I would like to thank and compliment and salute the organizers of this panel, because I think they just did a phenomenal job